It's my pleasure to be here representing the Foundation for Women and Girls with Blood Disorders. The topic I am going to speak on is about women and girls with hemophilia and increasing awareness of this disorder and the wide variability that we see in clinical phenotype. My name is Sarah O'Brien. I'm a pediatric hematologist. I work at Nationwide Children's Hospital, which is affiliated with the Ohio State University College of Medicine. I do not have any disclosures that are relevant to today's presentation. The points that I would like to cover include the importance of awareness of women and girls with hemophilia. We'll talk a little bit about the epidemiology of bleeding in these patients, and especially about hemarthrosis, since this is a symptom fairly unique to hemophilia. And then finally, we'll talk about what we know so far regarding the ability to predict bleeding phenotype in a woman and girl with hemophilia. Luckily, there's definitely increasing global interest in this patient population, and the studies that I'm going to talk about today come from all over the world. I wanted to start with two cases that I have seen in my practice over the last few years. The first patient is a 12-year-old female who was referred to our Young Women's Bleeding Disorder Clinic for heavy menstrual bleeding. Taking a history, she certainly had heavy menstrual bleeding. On review of systems, she also reported easy bruising, although she had undergone tonsillectomy without excessive bleeding. Her mother accompanied her to the visit, and we learned that the mother also had a history of heavy menses. She had had 2 children and experienced postpartum hemorrhages after both deliveries. The maternal grandfather had mild hemophilia. He's not followed in an HTC, but by one of our local hematology providers. And mom didn't know much about his experience with hemophilia, but she did know that he received factor VIII infusions prior to surgery, and she thought his disease was mild. What I thought was fascinating about this visit was that this bullet point here did not come up in the referral, did not come up at the beginning. It did not come up until I got to the family history and specifically said, does anybody in the family have problems with bleeding or a bleeding disorder? And that's because it had honestly never occurred to the mother that her family history of hemophilia was in any way related to her experience with bleeding or her daughter's experience with bleeding, because hemophilia only occurs in men, right? We did some laboratory testing, and I found that the factor VIII level was 53%, which of course would be in the normal range, but on the lower end of the normal range. We then moved forward with genetic testing, which demonstrated a variant of unknown significance in the factor VIII gene. We then had the grandfather tested, although I have to say this was a bit of a fight. When mom spoke to her dad about it and dad spoke to his hematologist told him that this was completely unrelated and that I, meaning me, was barking up the wrong tree. But he did undergo genetic testing and was found to have the same variant as his granddaughter. So of course, we are now classifying that as a variant of likely significance in the factor VIII gene. The second case is a patient that was referred to me from adolescent medicine. My colleague in adolescent medicine had been following this patient for a few years, and she had been experiencing heavy menses since the age of 11. She had undergone placement of an IUD, but was still experiencing breakthrough bleeding that was heavy enough that she was also requiring oral contraceptives. On review of systems, she was also experiencing gum bleeding and prolonged bleeding after minor lacerations. This family did not have a lot of information about family history, but there was definitely not a known history of hemophilia or any other bleeding disorders in the family. I did an initial von Willebrand panel. The von Willebrand antigen and activity were both normal, but I thought it was interesting that the factor VIII level was 44%. And remember, this patient was on an estrogen-containing contraceptive at the time I met her. She was able to eventually wean off of the oral contraceptive, and I repeated laboratory studies and found that her factor VIII level was now in the 25, 26% range. Her von Willebrand levels were still normal. So we went forward with genetic testing, and we found a likely pathogenic mutation in factor VIII. And several other members in the family who have bleeding are now undergoing genetic testing. Again, and I'll throw my own institution under the bus here, a maternal cousin of my patient presented to the hospital the following year with heavy menses, requiring admission to the hospital and the blood transfusion. And the family relayed that about my patient and that she had hemophilia, and they were told, oh no, that has nothing to do with this. You must be mistaken. Hemophilia only occurs in men. So much to learn, right? And so my first statement is just this really simple statement that women and girls with hemophilia bleed. And that hopefully seems obvious to many of us in the audience. But I think these cases just prove that it's not obvious to families necessarily, not necessarily to other hematologists in our community. And definitely a lot of awareness needs to go out to providers in other disciplines. Next, I'll review some of the studies that prove this point, that women and girls with hemophilia do bleed. The first study comes from the Global Emerging Hemostasis Panel, which is a collaboration between all of the countries that you see on the map here. And I'll be referring to this study as the GHEP study moving forward. So these investigators compared the ISTH BAT score in 168 hemophilia carriers as compared to healthy female controls. They found that the mean BAT score in the hemophilia carriers was 5.7 as compared to 1.4 in the age-matched controls. So just to put this into perspective for you, remember that the normal score for the ISTH BAT score in adult women is considered 5 or lower. We have the controls here, which are well within the normal range, but you can see that women and girls with hemophilia are not only different than the controls, but also the mean is a bit above what we would consider normal. In this cohort, the most commonly reported symptoms were heavy menses, oral cavity bleeding, postpartum hemorrhage, and excessive bleeding after tooth extraction. This study comes from investigators, Dr. Allison Wheeler and Dr. Robert Sidonio and colleagues in the United States. And they did a similar study comparing carriers of hemophilia A to healthy controls. The bars in blue are the hemophilia A carriers, the bars in red are the healthy controls. And you can see that almost across the board, bleeding symptoms were more common in the women and girls who were hemophilia carriers. Other commonly reported symptoms in this paper and other papers that have been published and are referenced here at the bottom include cutaneous bleeding, epistaxis, and post-surgical bleeding. I thought this paper was particularly interesting. It comes from a cohort in China, and what's a little bit different here is that these were not hemophilia carriers that were being seen in a hematology clinic, but women who were simply in the clinic because they were accompanying a male relative to the visit. Even in this case, where these are not, quote, patients, but just known carriers, they still had BAT scores that were statistically significantly higher than the control population, 3 as compared to 1. And we're not surprised to see that their BAT scores are lower than the ones we saw in the GHEP study, since again, these were not active patients. These investigators also looked specifically at bleeding after IUD placement and surgical abortion, as these are fairly common procedures in their region. And they did find a fairly high prevalence of excessive bleeding after these procedures. So I think these studies show across the board that yes, women and girls with hemophilia can bleed. This slide is again from this cohort in China. And the point I want to make here is just the variability in the bleeding score. So the bars in black are the hemophilia carriers, and you can see that the bleeding scores ranged all the way from 0 to 20, so quite a large range. I want to touch quickly on hemarthrosis in women and girls with hemophilia because we've learned a lot about this recently, and it's a symptom that is fairly unique to the bleeding disorder of hemophilia. So we've known for a while that those rare females who do have severe factor VIII or factor IX deficiency, meaning that they have very low levels of these factors, do experience joint bleeding with a similar frequency as compared to affected males of the same severity level. So a woman with a factor VIII level of 1% is going to have joint bleeding similar to a male with hemophilia who has a factor level of 1%. But what more recent evidence has highlighted is that joint bleeding affects a much broader portion of the carrier community, with reported frequencies varying from 4 to 19%. Dr. Sidonian and his group have done two important studies in this area, demonstrating that carriers may also be experiencing subclinical joint bleeding. In the first study, they examined 451 carriers who were enrolled in the CDC's database, and they found that they had decreased range of motion compared to a control population. And these were standardized physical therapy examinations of the range of motion in a variety of joints. In a separate project, these investigators looked at 9 carriers with decreased range of motion who agreed to undergo targeted joint MRI. And in this case, across the board, these women were found to have soft tissue and osteochondral changes that were suggestive of subclinical bleeding. So I think we definitely have a lot more to learn about this, and learning what the prevalence of subclinical bleeding is in this population and how that may be impacting joint issues later in life, for example. Next, I want to talk about the variability in bleeding phenotype in women and girls with hemophilia. As healthcare providers, we all want that crystal ball so that we can tell our patients exactly what to expect when it comes to their bleeding disorder. And when we talk about males with hemophilia, it's a little bit easier to be able to do this. If we are meeting a new baby boy with a factor level of less than 1%, or a factor level of 2%, or a factor level of 20%, we can give that family a reasonable idea of what type of bleeding their son may experience. But a major challenge in the care of women and girls with hemophilia is this wide variability in both their baseline factor levels and their bleeding phenotype. In the GHEB study that I referenced earlier, we talked about how the BAT score among the 168 carriers was higher than that in controls. But there was also a broad range, ranging from 0 to 35. Given this variability, investigators have sought to determine, are there risk factors for bleeding in women and girls with hemophilia? The first obvious place to look seems to be the factor level, right? We would expect that if the factor level is lower, the bleeding symptoms will be higher. In the Chinese cohort that I mentioned, there was no significant correlation found between ISTH BAT scores and factor levels. In the GHEB cohort, there was a significant but weak negative correlation between factor levels and bleeding scores. And in a Swedish cohort, only a weak correlation was identified between bleeding scores and factor VIII levels. Shows the link between factor level and bleeding in the GHEB cohort. This study included patients who were carriers of both factor VIII and factor IX deficiency. You can see that there is a bit of a pattern here, and the investigators did find a statistically significant correlation. But I hope you can appreciate that there is a large amount of variability here. We have patients over at the left side of the graph who have low factor levels, but normal bleeding scores. Their bleeding scores are less than 5. But on the right side of the figure, We have patients who have normal factor levels, but fairly high bleeding scores. So the answer does not lie in the factor level alone, definitely. Two studies looking at the response of hemophilia A carriers to desmopressin may provide some insight into why the factor level is not predictive of bleeding. So in one study of 25 obligate carriers, the investigators found that while von Willebrand factor increased throughout the 2-hour time frame after the DDAVP was administered, the factor VIII level peaked but then decreased. And in a recent study comparing carriers and healthy controls, again, the carriers had a reduced response to DDAVP. And these investigators found that women with abnormal bleeding scores had a significantly lower factor VIII response compared to those with normal bleeding scores. This figure comes from the more recent study looking at DDAVP response in carriers. The carriers are in the red bar and the controls are in the blue bar. And you can see that across the board, the carriers are having a reduced response to DDAVP, and their factor VIII levels are lower at the 1 hour, 2 hour, and then again at the 4-hour time points. These two studies suggest that the issue may be factor VIII's response to hemostatic stress as the cause of bleeding rather than simply the quantity of factor VIII. So are we looking at a difference in quality as opposed to quantity? For example, thinking about the Swedish national champion women's soccer team as compared to an American girls soccer team. They both have the same amount of players on them, but there's something inherently different about the players on these teams. Again, we have a lot to learn here. This doesn't explain anything about women with factor IX deficiency, but I think is an interesting clue and shows the need to investigate further. So if factor level is not the answer, what about genotype? Does that influence phenotype? The data here aren't very strong either. A German study of 46 carriers did find a correlation between the severity of bleeding tendency in carriers and the type of factor VIII gene mutation that they carried. But in the larger JIHAD study, no differences were identified in bleeding scores or factor levels between carriers with null mutations and those with non-null mutations. This study, I think, shows more clearly than anything that genotype is not always related to phenotype. This is a study of a large Amish pedigree. So these are 65 carriers of hemophilia B, and they all have the same founder mutation. So this is the same family. And even in this one family, the factor IX levels ranged from 19 to 114%. And the BAT scores ranged from 1 to 8. And again, this figure just makes the point that as the factor IX activity increases, that doesn't necessarily mean that the bleeding score is going down. There were patients with normal factor IX activity and elevated bleeding scores. So I hope during this session, you've appreciated the need to keep women and girls with hemophilia in your differential when you're evaluating a new patient with easy bleeding, even if there is not a family history of hemophilia. In general, we learned that women and girls with hemophilia are more likely to have bleeding symptoms than healthy controls, and this occurs regardless of their factor level. We learned that the bleeding phenotype in women and girls with hemophilia is highly variable, and that symptoms could include clinical and subclinical hemarthrosis, but that bleeding cannot be clearly predicted by factor level or genotype. We talked about two small studies of DDAVP in women who carry factor VIII deficiency, which may explain why factor 11 alone does not predict bleeding and supports the importance of more work into the pathophysiology of bleeding in this patient population. Thank you so much for your attention, and I look forward to answering questions with my fellow speakers at the end of today's session. Thank you.